My name is Elizabeth Lee. I'm a fellow in the Department of Radiology at the University of Michigan, and we'll be discussing the role of CT in imaging of esophageal cancer. Objectives for this presentation include developing an understanding for the role as well as limitations of CT in staging of esophageal cancer. We will first start with a pre-lecture assessment question. CT for staging of esophageal cancer allows for optimal assessment of A. The degree of esophageal wall involvement, B. Local paraesophageal lymph node metastatic disease, C. Sites of distant metastatic disease, or D. All of the above. Contrast-enhanced CT of the chest and abdomen can help identify sites of metastatic disease and whether there is possible invasion of the tumor into adjacent structures such as the trachea. Optimal imaging technique is performed with both oral and intravenous contrast when possible given patient factors such as GFR in order to increase the conspicuity of the primary tumor and metastatic disease if present. The TNM classification of esophageal cancer uses depth of tumor invasion into the esophageal wall, lymph node involvement, and the presence of metastatic disease to stage patients and determine treatment plans. CT can provide information regarding each of these. The T stage is divided by the layers of the esophageal wall, with higher T stages indicating deeper invasion. CT, however, is not able to differentiate between T1, T2, and T3 disease accurately. This EUS image shows an isoechoic mass, denoted by the blue calibers, invading into the muscularis propria, that is T2 disease. On the corresponding CT image, the tumor is not discernible, let alone the degree of wall invasion. Although CT is not able to determine T1 to T3 disease, it may allow for exclusion of T4 disease if there is preservation of the fat planes between the tumor and adjacent structures, as shown on this CT image. CT may be able to suggest T4 disease if findings such as loss of intervening fat planes, displacement of mediastinal structures, greater than 90-degree contact of the tumor with aorta, or pericardial thickening or effusions are present. However, the reported sensitivities and specificities of these findings in the literature varies. Therefore, even if intervening fat planes are lost on CT, T4 disease may not be present if the patient is taken to the operating room. Here is an example of T4 disease. On this contrast-enhanced CT, there is extensive soft tissue abnormality in the mediastinum due to esophageal cancer. The tumor abuts the posterior trachea, indenting its wall, and there is loss of the normal intervening fat planes. In addition, there is loss of the fat plane between the esophagus and the aorta. Abnormal foci of gas are seen anterior to the descending thoracic aorta, as well as extravasation of intravenous contrast into the esophagus due to an aortoesophageal fistula. Here is another example of T4 disease. On this contrast-enhanced CT, there's esophageal wall thickening and abnormal soft tissue attenuation within the superior mediastinum. A necrotic central component of the mass is noted near the great vessels. The tracheal diameter is diminished with irregularity of the wall due to tracheal invasion of esophageal cancer with fistula formation. CT can be used to assess for regional lymph node involvement, or end stage. The sensitivity of CT, however, is poor, ranging between 42 and 50%. And this is due to the fact that normal-sized lymph nodes may have metastatic disease. Specificity of lymph node enlargement is better, with reported ranges of 83 to 93%. An example of regional lymph node involvement. This gastrohepatic lymph node, measuring greater than 1 centimeter, is concerning for regional lymph node involvement in this patient with a distal esophageal cancer. M stage divides those with and those without distant metastatic disease and is a strength of CT in the imaging of esophageal cancer. The most common sites of metastatic disease from esophageal cancer include the liver, lungs, bone, and adrenal glands. Here is an example of a metastatic lesion to the liver from esophageal cancer. An ill-defined, hypoenhancing mass is present within the anterior portion of the right lobe of the liver. Another example of metastatic disease from esophageal cancer. Numerous lobulated pulmonary nodules are present in the lower lobes. There are additional limits of CT. First, in patients with symptoms suggestive of esophageal cancer, CT should not be used for initial assessment given its limited sensitivity. Secondly, as discussed before, CT cannot distinguish T1 to T3 disease given its poor spatial resolution when compared to EUS. Finally, EUS is more sensitive than CT when assessing regional lymph nodes for the presence of metastatic disease. An example of the inability of CT to identify primary tumors. On this contrast-enhanced CT of the esophagus, the wall thickness is normal and the normal fat planes are present. The PET scan, however, clearly demarks a hypermetabolic focus in the distal esophagus representing the patient's primary tumor. Now for our post-lecture question. CT, for the staging of esophageal cancer, allows for optimal assessment of A. The degree of esophageal wall involvement, B. Local paraesophageal lymph node metastatic disease, C. Sites of distant metastatic disease, or D. All of the above. The best answer is C. Sites of metastatic disease. Esophageal wall invasion is better assessed with EUS as CT has limited ability to determine the degree of esophageal wall involvement, that is T1 to T3 disease. Local paraesophageal lymph node involvement is also more sensitive when assessed with EUS compared to CT. These are our take-home points. CT of the chest and abdomen for the staging of esophageal cancer allows for identification of sites of distant metastatic disease, may help identify gross mediastinal invasion, and is specific for regional lymph node disease when lymph nodes are enlarged. The findings on CT can help guide clinicians in initial staging and appropriate therapeutic options. Thank you for your attention. I hope you enjoy the remainder of the course.
Good morning. My name is Kar-Kit Wong. I'm a nuclear medicine physician at the University of Michigan. We're going to be going through PET-CT imaging of esophageal cancer. The objectives of the talk are to appreciate the diagnosis, staging, workup and management of esophageal cancer, to describe typical FDG PET-CT findings of the primary tumor, regional and distant metastases, to review indications and test performance of FDG PET-CT for staging and restaging compared to standard anatomic imaging, CT, and endoscopic ultrasound. A question: which of the following statements regarding FDG PET-CT imaging of esophageal cancer is true? A. PET-CT has a high, greater than 90% sensitivity for detecting T1 and T2 primary esophageal cancers. B. The introduction of PET-CT for preoperative staging has made CT and endoscopic ultrasound obsolete. C. PET-CT has superior specificity than CT and endoscopic ultrasound for staging of regional nodal metastases. And D. PET-CT performs poorly for detecting distant metastases to bone. Esophageal cancer is a rare tumor, 10% of all gastrointestinal malignancies with a poor 5-year survival between 14 to 20%. Squamous cell cancer accounts for 50 to 70%, and adenocarcinoma 30 to 50% of all cancers. Squamous cell cancer affects the middle and distal thirds, and alcohol and smoking are risk factors. Adenocarcinoma is becoming more common and affects the distal part, and this is associated with Barrett's esophagus. Only 15% of esophageal cancers are proximal third tumors. The esophagus does not have a serosa, therefore infiltration into the mediastinum occurs early. The esophagus is lymphatic and vascular rich, therefore it's prone to having early nodal and distant metastatic disease. Distant sites are the liver, adrenal, lung, and bone, with spread at diagnosis of 20 to 30% of cases. Early stage disease is often asymptomatic, however late stage disease presents with dysphagia due to obstruction. Staging of esophageal cancer follows the American Joint Committee on Cancer 7th edition T&M staging system. The 7th edition defines regional nodes to the level of the celiac axis. The number of disease nodes may be more important for prognosis rather than the actual sites of these nodes. This is an example of the T staging system. A TX score is when the primary tumor cannot be assessed. Very early small tumors are T1, T1b invading the submucosa, and large invasive tumors are T4, being T4a resectable or T4b unresectable. In terms of the end stage, when you have N0, there's no evidence of regional lymph node metastases, and then you can have N1, N2, or N3 disease depending on the number of lymph nodes. The individual T, N, and M scores are combined to reach a stage 1 to 4, with 4 being the presence of distant metastatic disease. 54 to 69% of patients are eligible for surgery. The mean survival after surgery, however, is only 13 to 19%. Neoadjuvant chemotherapy and external beam radiation therapy prior to operation is gaining acceptance. The conventional workup is fluoroscopy, CT, MRI, endoscopic ultrasound. PET-CT, positron emission tomography with hybrid CT, using 18F fluorodeoxyglucose is a relatively new imaging modality. Adenocarcinoma and squamous cell carcinoma have overall similar metabolic signatures. Adenocarcinomas, mucinous types near the gastroesophageal junction, may have slightly less FDG uptake than squamous cell cancers. The majority, though not all literature, support the intensity of FDG uptake as correlated to survival. FDG uptake is a prognostic indicator. Primary tumor SUVs of less than 3.0 have better survival. Prognostic indicators such as the length of tumor, number of N1 positive lymph nodes, and distant FDG avid sites also predict a lower survival. Indications for PET-CT include a strategy to detect distant metastases at diagnosis, improving the specificity of lymph node staging, combining PET-CT and endoscopic ultrasound guided biopsy as a preoperative workup for the highest nodal yield. PET-CT performance. For local regional staging, PET-CT has a sensitivity of 51% and a specificity of 94%. For distant staging, it has a sensitivity of 67% and a specificity of 84%. For the primary tumor, PET-CT has overall sensitivity of 80% for primary esophageal cancer. The sensitivity is close to 100% for large tumors T3 and T4, but the sensitivity is only 43% for smaller T1 tumors. PET-CT cannot detect in situ or T1A tumors. PET-CT cannot determine the T stage of an esophageal cancer. This is a PET-CT scan which shows intense FDG uptake in the distal esophagus. The fusion FDG PET-CT images show that it's localized to the distal esophagus. This image shows the PET on the top and the fusion PET-CT on the bottom. There are FDG avid lung nodules compatible with nodal metastatic disease. This is a different case. There is intense FDG uptake which localizes to the upper cervical esophagus with circumferential mucosal thickening. This is compatible with a cervical esophageal cancer. This PET image shows FDG uptake in a prevascular lymph node. This is compatible with nodal metastatic disease. This axial image shows FDG uptake in a lung nodule in the right middle lobe. This is compatible with lung metastasis. Some pitfalls of FDG PET-CT are that mild esophageal uptake with an SUV max of less than 4 may actually relate to esophagitis or low esophageal sphincter activity. Hiatal hernias, benign stricture after dilatations, post-biopsy, and esophageal leiomyomas can have mild FDG uptake. These are sources of false positive results. Small intracapsular nodal metastases have a high false negative rate. Intense uptake in the primary tumor may obscure subtle abnormal adjacent nodes. Synchronous primary neoplasms are found in 5.5 to 8% of patients with esophageal cancer on PET scanning. PET-CT compared to CT and endoscopic ultrasound combination for nodal staging shows that PET, although being less sensitive, 22%, has a very high specificity of 91% compared to CT/EUS, 83% sensitivity but only 45% specificity. Therefore, the combination of PET-CT and CT/EUS would have the highest diagnostic accuracy. PET-CT versus CT for distant M1 disease, the PET scan has a sensitivity of 69% and a specificity of 93%, whereas the CT has only a sensitivity of 46% and a lower specificity of 74%. And PET-CT versus CT for M1 bone disease, the PET has a sensitivity of 92% and a specificity of 94%, which is superior to CT of 77% and specificity of 84%. This is a case showing FDG-avid bone metastases, and the arrow is localizing lumbar spine bone metastases in this patient with esophageal cancer. These axial images show FDG-avid rib metastases. This image in the same patient shows FDG-avid bone metastases to the right pubic symphysis and the left femoral head. The impact of PET-CT on patient management is that it will change staging in 14% of patients. PET will find distant metastatic disease in an additional 5 to 8% of patients after conventional imaging workup. PET is insensitive for local regional disease and does not replace CT/endoscopic ultrasound for detection of nodal disease. PET is more specific than CT/endoscopic ultrasound for regional distant disease. Using PET-CT for detection of recurrences, 2/3 of patients relapse within 1 to 2 years after their diagnosis. For restaging, PET-CT has been shown to have a sensitivity of 94% and a specificity of 82% for detection of recurrent metastatic disease. PET is not clearly better than the conventional modalities CT and MRI. PERSIST is an acronym for Therapeutic Response Criteria based on PET imaging. RECIST is an acronym for Therapeutic Response Criteria based on CT, which looks at changes in size of tumor sites. By using PERSIST criteria, which is based on the metabolic signature, which is the FDG uptake in tumor and the changes after treatment, treatment response monitoring is better than using the older RECIST criteria. Responders versus non-responders on early response PET-CT is associated with better survival in some studies, with a threshold of SUV reduction between 30 to 80% being advocated. PET cannot exclude minimal residual disease, as there is cases of significant recurrence even after an SUV decline. So going back to the multi-choice question from earlier, which of the following statements regarding FDG PET-CT imaging of esophageal cancer is true? answer is C, that PET-CT has superior specificity than CT/endoscopic ultrasound for staging of regional nodal metastases. Therefore, the combination of PET-CT with CT and endoscopic ultrasound together would have the highest diagnostic accuracy. Some take-home points. Esophageal cancer is a biologically aggressive, metabolically active malignancy. FDG PET-CT is a useful imaging modality for staging and restaging of esophageal cancer, prognostication, and assessing treatment response. FDG PET-CT has good specificity for local regional nodal metastases. FDG PET-CT is a whole-body technique with good accuracy for distant metastatic disease. This is a bibliography of relevant articles on PET-CT for esophageal cancer. So PET-CT is a relatively new, very powerful imaging modality for the diagnosis and staging of a wide range of cancers, including esophageal cancer. I'd like to thank you for your participation in this educational lecture. Hope that it's been helpful. Thank you.
Hello, welcome to the Thoracic Oncology course. My name is Arthio Zabeidi. I'm one of the advanced endoscopists here at the University of Michigan and the Department of Gastroenterology. Today we're going to be talking about endoscopic TN staging and management of early stage esophageal cancer. This is a big topic. This is what I do every day and I love. So it was a little difficult for me to be able to cram all this stuff in for you guys. So we actually divided this into a few parts. So we're going to have part 1, 2, and 3, and I will see you for all of those. The objectives for part 1 are going to be reviewing the esophageal wall anatomy, which is critical for everything that we're going to talk about, and you're going to come to see that very shortly. And we're going to review briefly esophageal cancer so you know what it is that we're talking about and what we're dealing with before we discuss how to manage it and how to stage it. One of our pre-lecture questions that I'm going to introduce to you is as the follows. I'd like for you guys to keep these questions in mind whenever we're going through the lecture itself to see if you can pick up on what the answer is and the justification and the reasoning behind it. So the first question is, let's figure out what is the correct esophageal wall anatomy going from luminal to the mediastinal surface. A is lamina propria, muscularis propria, submucosa, muscularis mucosa, and then adventitia. B is lamina propria, submucosa, muscularis mucosa, adventitia, and serosa. C, lamina propria, muscularis mucosa, submucosa, muscularis propria, and adventitia. D, lamina propria, muscularis mucosa, submucosa, adventitia, and serosa. A lot of words there, but hopefully by the end of this lecture, you guys are going to be able to figure that out. Question number 2 is looking at the risk factors for esophageal adenocarcinoma. So all of the following are risk factors for esophageal adeno except A, alcohol, B, gastroesophageal reflux disease, or GERD, C, obesity, D, tobacco, E, Barrett's esophagus. Question number 3, the most optimal assessment of treatment effect post-radiation therapy and chemotherapy is A, EUS, B, CT, C, MRI, or D, FDG PET imaging. Number 4, tumor extending into the submucosa would be staged as what? T1A, T1B, T2. T3, or T4. Number 5, the most accurate way to obtain information on pre-treatment T-staging is A, EGD with FNA. FNA stands for fine needle aspiration. B, EUS. C, a PET CT. D, a regular CT. Or E, MRI. Let's start out by sort of giving an overview of esophageal cancer. This is some Sears data, and this shows that the incidence of esophageal cancer, if you look, represents about 1% of all the new cancer cases in the United States. It ranks about 18th in the most common types of cancer, with number 1 and number 2 being breast and lung, as you can see here. An interesting thing to note, though, is as time has progressed and as medical therapy has evolved and progressed as well, we're seeing that these patients are surviving. So you can see in 1975, the 5-year related survival was only 4%, which is really dismal. And if you look at 2007, it's up to 21.6%. And I think that's in part not only to the chemoradiation therapy advances, but also in the fact that we've had surgical advances, as well as advances in minimally invasive endoscopic management of these lesions as well. Adenocarcinoma in this country is the most common esophageal cancer. The incidence is about 5.31 out of 100,000 cases. The risk factors are interesting because if you note, alcohol is not a risk factor for adenocarcinoma. We do see Barrett's esophagus, GERD or gastroesophageal reflux disease, smoking, obesity, the male sex, and white race all considered risk factors for adenocarcinoma. Another interesting point is to note that this cancer often occurs in the distal esophagus almost 75% of the time. So we cannot talk about adenocarcinoma without touching on Barrett's esophagus first. Barrett's esophagus is essentially replacement of the normal squamous lining of the esophagus with a more columnar intestinal tissue. What we can see endoscopically here on the right is that you have a normal pink esophageal tissue right here. And this is the healthy squamous tissue that we should normally see. And in addition to that, you see this very sort of salmon, beefy, pink-looking tissue. And that's actually columnar intestinal tissue. So it's columnar epithelialization of the esophagus. If you look on the cartoon here on the left, you see our normal GE junction would be around here. And our Z line, which you can oftentimes see in our reports, is actually that junction between the normal squamous and the columnar tissue. Here you can see that the Z line is not regular, where it should normally be right here at the GE junction. You see the columnar tissue is now extending up in this irregular, sort of erratic fashion up into where the squamous lining is. And that's why whenever we describe our Z line, if it's not at the same point as your GE junction, you know that there's Barrett's esophagus there. So the reason we talk about Barrett's esophagus anytime we're talking about adenocarcinoma is just like we see in colon cancer with adenomatous polyps progressing to cancer, we see the same thing in the esophagus. If you look on this representation, it's a British spelling of esophagitis and esophagus. It's not a typo. You see reflux, which is one of the precursors oftentimes for Barrett's esophagus, resulting in inflammation. So you end up going from this very normal esophagus, but you may or may not have esophagitis. Many patients actually will present just for an EGD, upper endoscopy, for no reason in particular related to reflux symptoms, and you'll see that they actually have inflammation and they're completely asymptomatic. Or they can have reports of no inflammation that they've ever had either a history of or symptoms of, and you see Barrett's esophagus. So that's why the plus or minus esophagitis is sort of out of the necessary algorithm, but it is important to keep in mind. So we go from normal esophagus here. There may or may not be esophagitis, and you add this component of reflux and inflammation, and you develop Barrett's esophagus, which again is the columnar intestinal epithelialization of the normal squamous esophageal tissue. Now, when you have Barrett's esophagus, the next stage in progression is low-grade dysplasia, which then progresses to high-grade dysplasia, which then progresses to adenocarcinoma. Whenever we talk to patients in clinic and they present at any one of these stages, each of them carry its own risk for adenocarcinoma. So if you see just having a diagnosis of Barrett's esophagus with no degree of dysplasia carries about a 0.5% risk of development of adenocarcinoma. Whenever you get to low-grade dysplasia, we quote somewhere from between 0.5 to 8%, and high-grade dysplasia at 5 to 8%. So what are the risk factors for Barrett's esophagus? Well, age, the male gender, Caucasian ethnicity, having reflux symptoms lasting longer than 10 years duration. In addition to that, if you keep in mind what we just talked about, GERD, tobacco, and obesity are risk factors for developing esophageal carcinoma. So the next cancer we'll talk about is the squamous cell carcinoma. The incidence outside the United States is 140 out of 100,000 cases, and incidence within the United States is about 3 out of every 100,000 cases. Outside the United States, esophageal cancers tend to be squamous cell carcinomas. Within the United States, they tend to be the adenocarcinomas, which carry that with it that risk factor of obesity, and I think that relates to the obesity epidemic that we have within this country. This type of cancer can occur anywhere within the esophagus. It's male and female equal predominance. Within the United States, African Americans have a higher risk than Caucasians. Now, some of the things to keep in mind compared to the adenocarcinoma we just talked about, males have a higher risk of developing adenocarcinoma than females. It tends to be a higher risk in Caucasians, which is opposite here. And instead of happening anywhere in the esophagus, adenocarcinomas tend to develop in the lower distal esophagus. Other risk factors for squamous cell include alcohol, also different from what we talked about before, smoking, caustic ingestion, which can include things like lye, telosis, which is a genetic syndrome and is the only genetic syndrome which carries with it an increased risk of squamous cell carcinoma. It is characterized by hyperkeratosis of the palms and soles, as well as development of oral leukoplakia. Achalasia and dietary factors, including frequent ingestion of hot beverages and nitrosamines and pickled vegetables, are all risk factors for squamous cell development. There are other types of esophageal cancers, but they tend to be much less common. We can see sarcomas, lymphomas, carcinoids, and even melanomas, but like I said, those tend to be rare. If you're talking about esophageal cancer, you're usually talking about esophageal adenocarcinoma and squamous cell. Now, the thing about esophageal cancer is that it is notoriously aggressive, and it's for a few reasons. There is direct extension into adjacent structures and through the esophageal wall. And I think the fact that there's no serosal layer allows that to happen very easily, as opposed to anywhere else in the body. Just like any other type of cancer, there tends to be lymphatic spread as well as hematogenous metastasis. Because you have that extensive lymphatic drainage and you have those two separate plexuses with two directions of flow, you're not only getting intrathoracic, but as well as intra-abdominal nodal spread at the same time. Now that we've reviewed the esophageal cancers and we've gone through what the esophageal wall layers are, we're going to wrap this part up, and I'll see you in part 2, when we're going to actually go into the TN staging and we're going to see some echoendoscopic imaging so you have an understanding of what we actually see and how we actually stage these lesions before we go into part 3, where we discuss what we actually do about them. Hello, welcome back. We're going to now talk about the part 2 of our lecture series on endoscopic TN staging as well as management of early esophageal cancers. The objectives for part 2 are going to include basic TN staging, when we use the echo endoscope for staging, what are its pros and what are some of the limitations. Development of an appropriate treatment plan, all is dependent on stage. So you can see here the prognosis depends on local invasion and the presence of spread to regional and or distant structures within the thoracic cavity. Accurate staging is critical, like we said, in establishing a treatment plan. So what do we use whenever we're trying to stage these cancers? You can do CT, you can do a PET scan, and also EUS. In staging these, we use the AJCC TNM staging system, just as it is with many of the other cancers. So the depth of disease is key to staging, and that is sort of one of the big take-home points here. Establishing depth of invasion is critical because it also has an effect on whether or not we can offer curative endoscopic therapy as opposed to sending the patient directly for surgical management or chemo and radiation. So mucosal malignancies, which are called T1A, and we're going to go over the T staging here in just a moment, have an extremely low risk of lymph node progression. As soon as you get into the submucosa, it carries a higher risk of lymph node metastasis. Metastatic disease, you can see here, is present in only about 21% of SM1 lesions and 56% of SM3. We're going to talk about what those mean in a moment. So before we can talk about TNM staging, we need to talk about the esophageal wall layers. So if you see here on this diagram, we have the layers of the esophagus. This side would be the luminal layer, so when you're actually eating and putting food in. And this would be the outside, which is within the thoracic mediastinal cavity. Here you have the epithelium. The superficial layer right here is lamina propria. That is what we're going to refer to as layer 1. Layer 2 is the muscularis mucosa. Layer 3, submucosa. Layer 4, the muscularis propria. And then layer 5, the adventitia. Keep in mind, like we just said, the esophagus does not have a serosa like the other structures within the body. Now, what does this look like on an echo endoscope? Because that is the imaging modality that we were going to be using. So what you can see here is this is the image that we see whenever we put an echo endoscope down into the esophagus in a patient. What they're trying to show here is that oftentimes we'll put a balloon on the tip of the echo endoscope to allow us to get good apposition with the scope against the tissue plane. It also helps us to anchor the tissue to get a better imaging, move other structures out of the way and whatnot. So what you can see here, and it's a little difficult, but this very first bright white line is actually layer 1. Now if you remember that layer 1 was lamina propria. The second line, which is slightly darker, and we call that hypoechoic, is the muscularis mucosa. The third line, which again is hyperechoic because it's bright white, is the submucosa. The fourth line here again, hypoechoic, is actually the muscularis propria. And then this fifth bright white, sort of thicker area right here, it doesn't necessarily have to be, but on this image it does look thicker, is the adventitia. So let's talk about the TNM staging system. Again, this is a lot of material. You're not going to be expected to just be able to rattle this off the top of your head unless you choose to have a career in advanced endoscopy and then let me know. But essentially what I want you to take away from here is T is just the primary tumor, and staging, again, with T staging is how deep within the esophageal wall this is going. As soon as we get into the submucosa, you're talking about a T1 lesion. Anything going beyond the submucosa into the muscularis propria is T2, and adventitia is T3. Now again, for our purposes and what you're going to learn in the next part of this lecture, is that once you get into T2, we really aren't good at offering endoscopic curative management. So you're looking primarily at catching people when they're within this T1 stage for us to be able to offer something endoscopically. If you look here really briefly with the N staging, a little easier. So if you don't see any regional lymph node mets, that's excluding the celiac node, that's considered N0. If you have regional lymph node metastasis, that's considered N1. And if you just can't assess for it, then we call that NX. So TX is what we would write down if we just can't assess the tumor. Again, we tend to not use this phrase. This is just so that you have what the proper semantics would be. We just say that we weren't able to do the exam, either because we couldn't get the scope down or we just couldn't get good images. T0, there's no evidence of a primary tumor. Also, by the time it comes to us, we know there's a tumor there, and so this is never an issue. Now, TIS, also T in situ, is the cancer only in that epithelial layer. So it's that tissue above lamina propria or level 1. It has not started growing into the deeper layers, and this is also known as high-grade dysplasia. In the past, we used to call it carcinoma in situ, which is why TIS came into play. T1 is cancer growing into the tissue under the epithelium, such as the lamina propria, muscularis mucosa, or submucosa. So when we talk about T1 lesions, we further break that down into T1A or T1B. As soon as you get into T1B, that means you're starting to affect the submucosa, and that is the tissue area where only endoscopic submucosal dissection, or ESD, can be offered, not EMR, like we're going to talk about in the part 2 of this lecture series. If you're T1A, you're above the submucosa, and it's easier for us to treat that endoscopically. T2 means that you've gone into level 4 now, which is the muscularis propria. It's that thick muscle layer just beyond submucosa. T3 is now that the tissue has gone into level 5, which is the adventitia. And T4, meaning it's going into nearby structures. That could be the pericardium and the aorta, for example. When they talk about T4, again, to further break it down in terms of semantics, so this tends to not really be used in clinical practice. T4A is growing into the pleura, pericardium, or the diaphragm. T4B is growing into other structures such as the aorta, the spine, the trachea. Once you get to T4, whether it's A or B, doesn't really have too much of an impact whenever we are describing that to our surgical and our oncologic colleagues. So let's try to tie this together when we're talking about all of these structures, and then I'm showing you something on an echo endoscope. So when we put the scope down, again, this is going to be the luminal surface where your food's going to be passing, and this is deeper structures with the thoracic cavity and the mediastinum being out over here. You have the epithelium, and you have high-grade dysplasia. This was the TIS, or carcinoma in situ. It says not yet affected layer 1, which is the lamina propria right here. As soon as you get into layer 1, you're now looking at a T1 intramucosal lesion. This is the same thing as T1A. This is showing that there's either affecting the lamina propria, or it's also getting into the muscularis mucosa, which is layer 2. T1 submucosal, or T1B, is now showing that it's affecting this third layer. And this is the tumor that we have a harder time and we cannot address with endoscopic mucosal resection. It can be addressed with endoscopic submucosal dissection, which is gaining ground in the United States, but it's not as commonly done as the EMR techniques. T2 means that we've now gone beyond submucosa into level 4. T3 is showing that it's going beyond the muscularis propria into adventitia, and then T4 is showing that it's invading an adjacent structure here. It's the aorta, so theoretically it would be T4B. Here they're just trying to show you nodal metastasis, no nodal involvement, a normal, happy-looking sort of draping lymph node, as opposed to an enlarged, irregular lymph node that we see here, and then they've staged that as N1. So let's talk about the EUS as a modality for staging. EUS, or endoscopic ultrasound, is now considered the most accurate imaging modality to establish T-stage. It is better than CT or MR for preoperative T-staging. And if you look at the percentages, they're about 76 to 89% versus 49 to 59% accuracy. Obviously, as the tumor size increases and gets larger, it's better for us because we are more accurate, we have more tissue to work with, we get a clearer image whenever we're trying to stage these lesions. When we talk about end staging, EUS can accurately determine end staging in about 90% of superficial and partially obstructing lesions. Whenever we talk about lymph nodes on endoscopic ultrasound, we talk about the acoustic characteristics that can make it either seem more malignant or more benign. So things that sort of tip us off or raise our antenna about this lymph node looking abnormal and possibly being a malignant node is a size greater than 1 centimeter or 10 millimeters. If it's a very round and smooth, very clearly defined bordered node, the proximity obviously to the primary tumor, and if it's hypoechogenic. We'll talk about in the next slide what we see with a normal or benign looking lymph node, and you can sort of compare between the two. The accuracy of applying these acoustic characteristics approaches 80%. And if we do an FNA, which is a fine needle aspirate of the lymph node in question, we can increase that accuracy from 80 going up to 92 to 98%. So you can see here on 2 ultrasound images, we have a benign lymph node here. It's very hazy bordered. It's what we call, we wouldn't say it's hypoechoic, but it's more isoechoic, and iso meaning same echogenicity as what we compare to as the liver. So you have a very sort of bean-shaped, we call it draping or triangular node. The size you can't really tell here, but not a terribly large size. It's more isoechoic. Whereas if you see this malignant lymph node right here, it's dark, it's hypoechoic, it's very well defined. You can very clearly see what the borders are, which is why they've tried to also show this right here compared to this very sort of hazy looking thing. It's more round. It's not sort of bean or draping or triangular shaped like we will often describe. Now, these two don't necessarily correlate here because we're talking about benign and it's through this image and malignant with this image. But you can see how we describe it. So if we describe a node that's sort of draping, like I said, or triangular, fuzzy margined, or hyper or isoechoic, you're probably talking about a benign node. Whenever you start worrying is if it's hypoechoic, it's a very sharp margin, round or oval, and obviously the size greater than 1 centimeter. So the utility of EUS when we're using it to determine pretreatment staging and to identify cases of esophageal cancer that may or may not be amenable to our minimally invasive endoscopic therapy is sort of why EUS is superior. It can not only be used as a diagnostic tool, but theoretically at the time we can even, while we have a scope down, provide therapy as well. EUS can also be used to determine response to chemotherapy. Now this is going to be a little different here whenever it comes to radiation, and we're going to talk about that in a moment. EUS staging, the accuracy, like I said, decreases in cases when we can't get our EUS scope down beyond the tumor. There used to be a practice of going down and dilating these patients in order to get the endoscopic ultrasound scope down, but that carries a really high perforation rate, up to 24%, and a high mortality. So that is not a practice that, at least here at the University of Michigan, that we routinely carry out. Partial staging of the accessible area, meaning the area that we can actually see upstream, where our scope can go, risks understaging the lesion. And what I mean by that is what we see up top may not be what actually is happening throughout the lesion and sort of more distal into the area that we can't put our scope. So we may stage something as T2 or T3, and further down there actually is a T4 lesion. One thing that has been shown in terms of it being evidence-based is when we cannot pass our EUS scope through the stenotic tumor, T3 disease was present in 89% of those patients, and N2, N3 disease was present in about 63%. So when we sort of hit this barrier whenever we're doing our procedure on a patient that's being sent to us for treatment staging, if we can't pass the scope down, we do not dilate, we just abort the procedure and we send the patient for likely neoadjuvant therapy but most likely back to the referring surgeon or oncologist. What are the limitations of EUS? Because I'm thinking about all the glories, but every imaging modality has its limitations, and we need to keep those in mind whenever we're discussing that with patients, as well as interpreting the data. Obviously, endoscopic ultrasound is an imaging study, just like any transcutaneous ultrasound, is operator dependent. It is not as optimal as EMR or surgery for T-staging. And what I mean by that is these are all images that we are getting and we're seeing. And for somebody that has been doing this for 15, 20, 30 years, they can sometimes be duped by not correctly identifying what layer may or may not be hazy, let alone for you who's looking at this likely for the first time and can't make heads or tails of the dark line or the black line or the white line. So whenever you are able to do EMR or surgery, you're giving the pathologist tissue en bloc. They're actually looking at this under a microscope and they can see tissue in front of them to determine how deep and how accurate that would be in terms of neoplastic tissue going into the esophageal layers. Now, one thing to keep in mind with EUS is that staging and restaging after neoadjuvant chemo and radiation, it is not accurate. Radiation totally destroys all of our mucosal planes, and there's no way for us to distinguish in the vast majority of cases whether it's residual disease or whether it's radiation-induced mucosal injury. Oftentimes we go down and everything just looks obliterated. We can't make heads or tails of what is there or what's not. So whenever we're talking about T-staging, in these patients that have had chemo and radiation, you're getting a 29 to 60%, which is a huge range. But again, it just goes to show you that it's not the optimal test for T-staging these patients. 38 to 71% for N-staging. And we can get about to 78% whenever we're actually doing an FNA of an abnormal looking lymph node. Again, we're getting tissue for the pathologist to look at, which is why we can get that accuracy. But whenever you have a patient that is post-chemo radiation, sending them for restaging via EUS is not the way to go. The most optimal imaging modality for that is a PET scan. So now that we're sort of at the end of part one here, what are the things that I want you to be able to take away from this as you walk away from this lecture? I want you to know the esophageal walls, layers, because that is critical whenever you're talking about staging.